el tema, deja abierto el tema para que la gente pregunte lo que quiera. Ahí Oli estará
Sí,
siempre preparada para contestar cualquier pregunta, cualquier inquietud que tengan de saber de los temas más diversos que quieran saber de carácter
sí.
social.
También vamos a estar, ya se nos pasó ahorita el Día de Muertos, que es también un tema, ya sabes que es muy, muy bonito, muy enriquecedor, que ha crecido muchísimo. Ahora hay desfile de Catrinas, ahora hay muchas cosas en las
Ah,
ciudades.
hace un año nos
Entonces,
hablaste del tema, sí.
estas concepciones, estos conceptos de las pero también un poquitito vamos a hablar sobre la cultura y sobre las costumbres, sobre la gastronomía que tanto nos encanta a Betty y a mí. Ajá,
Perfecto.
la comida mexicana y la comida, vamos a hablar también de comida de nuestros hermanos latinoamericanos, también un poquito vamos a meter comida cubana, algún platillo o costumbres también de nuestros compatriotas, hermanos centroamericanos y sudamericanos.
Excelente, excelente, me gusta. Sí. Muy bien, pues Oli, ¿con qué nos despedimos? Que ya estamos casi por irnos del aire. ¿Con qué nos despedimos, mi Oli? Aparte de que ya dijiste que órale a opinar con Oli, o
Ahora
con
la pena,
Olivia, o con la licenciada. Yo pienso que con Oli se escucha así como más familiar, ¿no?
sí, con Oli, yo soy licenciada en contaduría, tengo una especialidad en finanzas, estoy haciendo una carrera en psicología y bueno, soy también consultora, tengo un coach empresarial. Los puedo apoyar en diversos temas, tanto en el del ámbito fiscal y contable como en humanidades o si quieren también familiar, también.
Excelente, muy bien, Oli. Pues, órale, a opinar con Oli. Fue el segmento de la licenciada Olivia. Así lo vamos a considerar y así se va a quedar. Órale, a opinar con Oli, donde nos estará transmitiendo.
Walk with me, Luna. Walk with me, Luna. So the story goes that my heart met yours. You touched my soul. It's you I adore. It's your beauty where I feel most free. It's you and me, and it's plain to see. I do, I do, I do, I do, I love you. I do, I do, I do, I do, I love you. Won't you walk with me? Not through the dark. Won't you walk with me? Not through the park. Won't you take my hand? Help me
And of course, you are listening to KXVS. Oh, no longer KXVS. It is now TVOSJ, the voice of San Joaquin.
And this is Bruce Judici with Connections at Peace and Justice Network on the radio. And tonight we are talking with Kathy Mathis, Dr. Kathy Mathis, and Max Heinemann. And we're going to be discussing the Medicare for All hearing that happened on April 30th. It was the first hearing that we've had on Medicare for All. And so it's a step forward.
Very exciting.
A nice article by The Intercept on April 30th that sort of gave sort of an outline on this. And I'd like to read a little bit from it and then have you guys jump in and fill in some of the blanks that may or may not be here, because it was a nice overview and it was an interesting hearing. It was a hearing before the Rules Committee, which is kind of a strange committee for a health bill. And it was, there were 6 people who testified, 4 who were who were nominally pro Medicare for All, and 2 who were not. And so let me start by just reading this. If Medicare for All is ever signed into law, what's known as The legislative history will date back to April 30th, 2019, and the first word heard by Congress on the question will have been from activist Ady Barkan. The legislative history will also reveal a quirk indicative of the tensions underlying the fight for single-payer health care. The first ever hearing on Medicare for All was hosted not before any of the major committees with jurisdiction over the legislation, but instead in the cramped quarters of the Rules Committee, which typically only sets terms under which bills will be considered on the House floor.
Well,
Representative,
but that's huge.
yeah,
I mean, if they determine what gets a vote,
indeed, and that's where a lot of bills do start, right?
and
you
where
have
a lot of bills die.
Yeah, where a lot of bills die. So Representative Tom Cole of Oklahoma, top-ranking Republican on the committee, Tom Cole, noted the unusually obscure venue for such a major piece of legislation. There is a reason, he said, suggesting that Democratic leadership and the chairs of the relevant committees were reluctant to grapple with the issue. That's because this is an extraordinary bill. And then the chair, Jim McGovern, says, I'd like to think that it's an enlightened chairman that motivated leadership to choose his panel for the history-making hearing. And Jim McGovern has been a leader in Medicare for All for a good long time. So, I mean, do you think that's true that they is this an unusually obscure venue for such a major piece of legislation, or is that just the Republican coming up with a negative talking
Well,
point?
I don't have any idea whether it's an obscure or not, but having McGovern be the chairman was really a godsend. He was very positive.
Now, is he a person who chose the folks who participated in this, or was that just sort of also Pelosi and everybody else? Because it sounds like the 6 people who were chosen weren't necessarily folks who were outspoken leaders in the Medicare for All
Well,
movement. Right?
McGovern did address that at the end. He did say that they wanted people, that they had been chosen because they were not vocal
Advocates.
advocates for single payer. Although Ady Barkan, who was added on,
Yeah.
I think has a long history of being a single
But
payer advocate.
Weren't there, the other night, you read something where there were some real limits on who could speak. They couldn't be
Right.
Political
Right, and I don't really know where those criteria came from.
They couldn't be
I have to
activists or
they couldn't-
advocates.
Right,
or-
they couldn't ever have said anything negative against the Affordable Care Act. They couldn't be advocates or activists. Those were three criteria.
Well, here they're saying that the Tuesday hearing marks the highest point yet in the movement for a single-payer health care, which has been debated since the advent of the New Deal. And if you don't remember the advent of the New Deal, those are in the 1930s. And that was, I'm sort of starting to remember that, but it was a long time ago, man.
Well, definitely in the 1940s. But yeah, I think Frances Perkins, who was the Secretary of Labor, I think she had that in mind. She didn't propose it as a real prospect, but dedefinitely Harry Truman was thinking about it.
Yeah, and there was I don't know if people thought that employer-based health insurance in this country was sort of a step in that direction, and that they might have gotten to a Medicare for All type of situation, but back in the 50s, employer-based health insurance was not very pricey. I mean, it was just a way to get around some of the wage controls that were happening during World War II. Is that they couldn't pay people more money for wages. So what they did was they added these benefits, and then after the war, then they persisted. And then we ended up getting Medicare in 1965. But so right now, this represents the hearing now represents a new phase in the process, coming after an organizing effort grew public support for single payer over the last several years, drawing energy from the 2016 presidential campaign of Senator Bernie Sanders. That organizing led to the introduction of the most detailed legislative proposals in the House and Senate yet, followed by the first hearing on Tuesday.
Yay.
Yeah, so
It was a big deal.
It was a big deal.
It was a big deal.
Yeah. So that's excellent. So what they went through here is talking about the different folks who were
On the panel.
Yeah, exactly. So so you actually watched the
I did. I watched the whole thing.
C-SPAN.
I didn't watch it live. I watched it that night. I was riveted. It was wonderful.
So there was a panel of 6, and I would guess it's still on YouTube, right?
I'm sure it is, or
Yeah.
on C-SPAN's,
Yeah.
you
It was,
channel.
so it was an April 30th hearing in the House Rules Committee. So if you want to Google that and try to find it, so there were 6 folks who were testifying.
Yes, if that includes Addie Barton.
Yeah.
So let me think. It's the.
So-
I've
so-
got the list of the witnesses.
So
who were
Addie Barkin
proposed
is an
before.
interesting one because
Yes.
he's a person who's afflicted with ALS
Mm-hmm.
and is confined to a wheelchair. And how can he communicate?
He had an artificial voice, which really sounded a lot better than I anticipated it
So
would.
like Steve
they've
Hawking or something.
Yeah, right.
Yeah,
Sounded
they've made,
just like
they've
Steve
made
Hawking.
some real strides in that technology.
Mm-hmm.
A lot of his remarks were prepared and
Mm-hmm.
definitely opened up the hearing with prepared remarks. They were very moving. But then later, he would take questions, and the person asking him the question would give him a few minutes to come up with an answer, and he would have a good answer. So
Wow.
I don't know how long he had to, if he actually had prepared it ahead of time, or if he was able to put phrases together. I don't really know how
Yeah.
that technology works.
The report here says that he told the committee that objections related to the cost of single payer are political, not economic, and that, quote, the richest country in the world, unquote, can afford to provide health insurance to its people. He also spoke of his personal experience being denied care by insurance companies and needing to spend his precious remaining time battling with them. His home health care costs are running at $9,000 per month.
Yes.
Yeah. So it sounds like it was a pretty moving testimony.
It was moving, and it was salient for any of us. I mean, how many of us would like to spend our last precious few weeks with our family, haggling with an insurance carrier about
Really?
co-pays, deductibles,
Indeed.
and whether something should be covered or not. And that $9,000 a week is so that he can stay home. If he were to accept Medicaid or whatever it is that's available to him, he would have to go into a nursing facility. And so he's scavenging money from friends and family so that he can stay home, which is
And he
a
would
tragedy.
not be available to do speaking like this if he were in a
Probably
nursing
not.
home.
Yeah, probably
Yeah.
not.
Yeah, so those costs, right now we are spent. I mean, so $9,000 is what it's cost now, and I would guess, that's just what a single payer would end up paying. But right now we're paying for a lot of overhead that could be transferred to those costs and maybe lower those costs. I mean, if a person who's currently working on on trying to deny care could actually provide care, maybe that person's cost could then be moved over to the above the line, above the operating cost line. I mean, it could actually go into the process of helping to serve people rather than to having to deny care. And
right.
so, because a lot of these costs that they talk about, I mean, there's after Barkin's moving testimony, the panel turned to Charles Blahaus, an economist for the Koch-funded Mercatus Center, and he
Say
talked
no more.
Yeah, and he talked about his analysis that projected costs for a 2017 version of the Medicare for All bill, which he pegged at $32 trillion or $3.2 trillion over 10 years, or $3.2 trillion for a year, far too expensive. And then, but then McGovern asked him and said, well, but Medicare for all would cost a little more or a little less than what we're currently paying. Is that right? And this guy says, I think that's fair. So when they throw out that $32 trillion,
Sounds like a big number.
yeah, they're saying like this $32 trillion is on top of what we're already paying. But no, what we're paying is, I mean,
Or it's a lot more than we're really
yeah,
paying,
it would be
or
on top of what
Not
we would be
really.
paying for if we had Medicare for all. We'd have to pay this additional $32 trillion. Where no, it's one $32 trillion or another $32 trillion, and the $32 trillion that would be Medicare for all would cover everybody, and so and not have these sorts of waiting times and that sort of thing.
Right.
Yeah.
And I mean, there's different ways that gets broken down. But they look at different ways of funding Medicare
Right.
for all, and it would be a sales tax, or there would a nominal sales tax. There would be a tax on manufacture. All corporations would pay a 7% tax on their gross income, but that ends up being about 9% less than if they provided health care for their workers.
Right, because right now a lot of employers are paying that. And in fact, a lot of employers who are smaller end up not being able to afford to provide health insurance at all for their employees. And so they end up, I happen to know of a veterinary clinic who is not able to provide benefits, and they regularly lose technicians to jobs like Subway or places that offer benefits. Because even though
they weren't giving them enough of
right,
those vet meds.
Well, the thing is they weren't able to provide health benefits, and so they lost probably somebody who's better at you lose people who have skills in certain areas to go into a job where they may not have any skills at all, just because because health benefits are offered.
Right.
So you end up having an economy that is functioning at below optimal, because you have people taking jobs not because they're good at it, but because the employer happens to be able to offer benefits. They're larger or however they're able to win it.
Kind of one of the things. So they had two presenters who were quite negative. But if you looked at their argument, they just didn't make much sense. I mean, there are all kinds of problems with the financing Medicare for all. I mean,
well, they really did. I mean, they didn't get into that a lot, which was good.
Yeah.
Because that's not what we need to discuss right now. Exactly how are we going to finance it? I know that's a big sticking point for a lot of people, but there are many ways that you could finance it,
Right.
and that was the point of one of the economists, and he kept saying back to the legislators, you'll have to decide how you want to how you would want to finance this. There are many ways to do it.
Because now we're financing it with premiums, co-pays, deductibles, and people going without service. That's how we're funding it now.
Right.
Yeah.
And but the two speakers who were so negative, they wanted to talk about how many $1 trillion it was going to be, and not talk about how you would get there. And they would say things like it would decrease the quality of care. They don't know that. As a matter of fact, it'll increase the quality of care, and totally decrease the cost. However, they choose to finance it.
Right. Because this person, Grace Marie Turner, from the president of Galen Institute, an organization that promotes public policy research on free market ideas for healthcare, she raised concerns about rationing healthcare and extreme wait times for citizens in countries that already have single-payer systems, like France or the United Kingdom. But some of these countries have already addressed long wait times. Sarah Collins of the Commonwealth Fund said.
Who spoke immediately after her.
And so she was able to rebut that, saying.
The numerous studies have debunked that.
Yeah,
the waiting time myth.
Yeah, and also she says that it doesn't mean that the single-payer system there is going to be the single-payer system here. The thing is there's no reason that necessarily. I mean, there's always going to be waiting times, unless you have an unlimited number of doctors who are just sitting around doing nothing. And that's I don't know if there's any country where that's happening. So I mean, you're always going to have a certain amount of decision making and saying that this procedure is more important to be seen today, and that procedure we can see in 2 weeks, and that procedure we can see in 2 months. And so the thing is that's called scheduling. But the thing is
triage.
Triage. Yeah, but when it turns out that prioritizing. But when it turns out that the person doesn't get seen for 6 months and then finds out that they can't afford treatment at all, that's not rationing at all. That's called being locked out of a system.
Yeah.
And so the fact that uninsured people in the United States still can't get coverage they need or choose to go without care over paying exorbitant costs essentially means that we too are rationing care.
Yes.
Yeah.
She pointed that out.
Yeah.
We are rationing care.
Yeah, and then there was a emergency room
Oh,
physician.
he was wonderful.
Yeah,
He-
Farzan Navi.
his initial testimony just brought the whole conversation into a very real
Yeah, personal.
sense of relief. I
Yeah.
mean,
Yeah.
you
He
could,
had
you could
several-
visualize these cases.
Yeah.
Several examples, personal examples that he had, where patients had left against medical advice and decompensated, and then spent many times more dollars, or died
Yeah.
because they left AMA.
Well, here's one. They said Navi shared a number of stories that highlighted how the current system is not just cruel, but also ineffective and even counterproductive. He talked about one patient who declined to be treated for appendicitis because she couldn't afford the CT scan and subsequent treatment. And another woman, declined to be treated for appendicitis. So isn't that, I mean, if you're not treated for appendicitis, can't that be fatal? I mean,
Yes.
that's
Well, he was quite worried about her.
Yeah.
He didn't really give us an answer as to what happened to her.
yeah.
But he was very worried that she would walk out the door and she might die. And he
Yeah.
told her that. And she said, I have to take that chance.
Well, and,
have to
and
take that
She had to
chance.
take that
he
chance.
he
couldn't-
was ordering a scan. What kind of scan was it?
CT.
CT
scan,
scan,
uh-huh.
and she couldn't afford it, and so she opted to not go ahead with the treatment.
Yeah, and and the thing is that you ought to, those who are listening this evening should think about folks that they know, and think about people who these sorts of parallel things have happened, and just, I mean, I bet just about everybody has an experience for somebody who has had such an experience with the medical system where they couldn't afford to do something, or they had to cut a tablet, or they had to skip a doctor appointment, or they just hoped that they got better because they couldn't afford to go and see it. Yeah, I feel really bad, but I just can't afford to see the doctor.
Or they didn't know where to go because they knew they couldn't go to Kaiser because they didn't have membership there, but they
Yeah.
didn't know where they could go.
Right.
Yeah.
Right. Another young woman came in to be treated for a routine urinary tract infection, but her insurance company denied her claim for antibiotics, and she couldn't afford the $300 medicine. Navi said. Instead, she bought some cranberry juice, which is just that's almost like antibiotics. 2 days later, she was back in the emergency room with sepsis and a high fever. Sepsis is
It's when the bacteria leaves the system that it's in, like left the bladder, left the kidneys, went into the bloodstream and started
Like an infection.
seeding other, a systemic infection, and it can actually lower your blood pressure to a very dangerous point.
She had to be admitted to the hospital, and he says, we denied her $300, but now we're paying thousands of dollars for that.
Yes.
In terms of, because the emergency room is a place where you don't have discretion. You have to accept somebody who is dying. And whereas this is a typical situation where, prevention is denied, and then you end up having the cure that is so much more expensive.
Yeah.
Yeah.
Yeah. End stage. End
Yeah,
stage.
yeah. Yeah. Another one of his patients couldn't afford antibiotics for a fever and decided instead she'd be better off going to a local pet store and buying antibiotics meant for fish. She overdosed and ended up in the emergency room days later with severe side effects that impacted her brain and central nervous system. She later had to be admitted to the intensive care unit, which is pretty darn expensive.
Yeah. That one. That
That's-
was a first for me. I hadn't heard a story like that.
Yeah, it's awful. Yeah, and I'm sure if you go to, this was one emergency room physician in New York.
Yeah, he
in New
works
York.
out of several,
Yeah.
2 or 3 different hospitals,
Yeah.
including the VA, which he said was wonderful,
Oh, really?
and that the patients there love the VA. Yeah.
Really?
Yeah, yeah.
Ah.
He just kind of slipped that one in.
Yeah.
But yeah.
Yeah, because the VA is a system. There are systems where there is health care for all for a certain membership.
Right.
So, like if you're a veteran, the
always go to VA.
the VA is health care for all if you're a member of that group. Now, Medicare is if you're over 65 or over, then if you're in that club, then you get Medicare for all. And then if you're low income and young, I believe you get Medicaid, right? Right.
Yeah.
So the folks who are not part of a club are folks who are like between 18 and 65.
Right. And then
who are not in the
some
military,
of them have
because
jobs
because
that,
people in the military also
right.
are part of that club.
Oh yeah.
And they have a
Actually, one qualifier to Medicare, if you're 65 and over, is it doesn't automatically include drugs.
Right. It doesn't cover 100%.
Right.
It covers 100% of hospitalization. Outpatient visits are 80%, and that 20% can be a very large amount.
Actually, it's a little less than 20%. It covers more than 80%. Now.
Yeah, so
close to 90.
So that's the way the system as it exists now. So the easiest thing to do to change over from where we are would be to say, okay, you're eligible. Everybody's eligible for Medicare right now, and so you can sign up tomorrow. And just
get
sign
your
up,
card.
Get your card, and do it, and then you don't have to worry about it anymore. And then what we can do is just figure out how we're going to pay for it. The many different methods that we can figure out. I mean, because what we would have done is taken the burden off of employers who no longer have to offer health insurance, don't have to pay for part of their employees. I mean, there has to be some sort of analysis to say, well, if businesses are benefiting because they're not having to offer health insurance any longer, well, I mean, that's really wonderful. But, if we just kept it at the status quo, we could just have them pay the same amount, and we could still call it a premium, and they can still pay it into just address the payment someplace else. It'll go to Medicare instead of it goes to Aetna or HealthNet or wherever. And it's just a numbers game. I mean, it's just a, it's a big
number.
It's
a big
number,
and you have to allocate payments to different people,
right?
Different entities, different parties,
right? But the system already exists. I mean, the framework is there. The doctors, the nurses. I mean, it's not like you have to create the medical system, which would be very difficult.
That
All we're
lady
talking
from
about
the
is
Galen Institute was pretty worked up about that one. She seemed to think we were going to be bulldozing hospitals and taking medical certificates away from people and starting from scratch. I don't know.
It would be like a merger, really. I mean, the thing is that in mergers you do end up having cost savings. And then you do end up having job losses.
There's
People get
winners
laid
and
off.
losers.
There are winners and losers.
Her statement was Americans want more, not fewer choices. Well, Medicare for All would give everybody pretty much a choice of any doctor that will take them.
That's a distracting argument. I think that's an argument for people
it's a
who
false
really
argument.
don't. It is, but on the surface, for someone who doesn't really understand the system, it sounds good. Because if you have lots of medical plans, you could have many to choose from. But the point is that each medical system only allows certain doctors in and certain hospitals in, and so when you have Medicare for All, there is
you don't
no
have to
need,
worry about whether it's a PPO or whether
there
it's
are
a
no limited
HMO
provider
or,
networks,
right? Yeah.
Gold, bronze, silver. Don't have to worry about whether or not how high you.
So Medicare for All actually provides people with more choice of their own.
You have choice of actual doctors rather than choice of insurance plans.
Or groups or network
insurance
groups.
companies or
I mean, I live up in, like I say, I've always, I live up in Calaveras County. We don't have choices. I mean, one year we get Anthem, then next time we get Blue Shield. But sometimes it's we end up I don't know if they just look at each other's notes, but it just seems like they're always sort of in lock. They're in lock. Yeah, we're Amador, Tuolumne, and any of those foothill counties are just there are no choices, and the hospitals don't want to take. They won't take certain insurances, Aetna or HealthNet. They don't even come up. And I don't know who else is out there anymore.
Well, then if you want mental health services, those are a carve out. No matter what insurance you get, they sub that off to some other company nobody's ever heard of.
Yeah. Fly-by-night mental health services. Very nice. This is Peace and Justice Connections Radio. We're talking about the Medicare for All after the first hearing that happened on April 30th. We're here with Dr. Kathy Mathis and Max Heinemann. And so, so it was a pretty it was a pretty interesting hearing. There was a person named Dr. Doris Brown, who is the immediate former president of the National Medical Association, which represents more than 30,000 African American physicians and their patients, and said that the Affordable Care Act, and it sounded like they weren't supposed to be criticizing it, but they said the Affordable Care Act didn't go far enough in addressing the ways in which current healthcare system fails African Americans. She says, quote, with numerous and often insurmountable obstacles to receiving quality health care, people of color experience differences in access to health care, the affordability of these services, implicit biases by some providers, and limited participation in clinical research, which has consequences around viable medical treatments. So this woman, who's a physician and a retired military officer, spoke about health equity, which refers to the state, quote, the state in which everyone has the opportunity to attain their full health potential and no one is disadvantaged, unquote. She said universal coverage is a pathway to achieving that state. It, quote, it has the potential to address poverty, inequality, and discrimination. So it sounds like, when people knock, and I don't want to get all political about it, but when people knock Bernie Sanders about his inability to communicate with African American voters, I would say that a Medicare for All system that is unabashed and that what he advocates is all about racial equality, and it's all about serving people on an even playing field. Whereas right now, you can have physicians pick and choose whoever they want to see. They can be in different networks, or they can just price themselves out of the system.
Mm-hmm.
Yeah, and Doris Brown also talked about the necessity to address the shortage of physicians and to ensure that all hospitals of all types are funded under the Medicare for All.
Yeah, because we were talking about that last time, and that's a pet peeve of mine, is that supply and demand is that, the reason why we have, such high... One of the reasons why we have such a high price for physicians is because we have such a limited supply of them. I mean, if we had more physicians out there, we wouldn't have to, for one thing, have to steal doctors from other countries where they're pretty well needed, and we would be able to serve. Allow a lot of people who want to go into medicine to actually get into medicine where they're denied right now, through a real rationing of how many doctors get through the whole system, through the 4 years of college, the 4 years of medical school, the 3 years of residency, and then if you want to do an internship, then or what is the fellowship, right, for a couple of years or something, and by the time you come out, you're 40 years old, and I guess you've served
$300,000 worth of debt.
Yeah, and I guess you've served some people along the way, but still, it's a way of really tying up people who have a lot of expertise, whereas I don't know. I mean, it's good to have that much practice, but I don't know. I think there should be some way to try to get more medical professionals through the system, so that we can, so we can use some of the savings that we have through this, getting rid of insurance companies, and really apply it to the providers.
Mm-hmm.
Yeah. So, because. Let's see, because health equity and opportunity are inextricably linked, when equity is achieved, there will be no health disparities, whether you call it universal coverage, single payer, Medicare for all, or some other label. The label is not the most important point. What is important is that the care must be of high quality, accessible, affordable, comprehensive, and coordinated.
Yeah, I do worry that she is not as committed to the single payer model of universal health care as we're going to need on the front lines, but she was extremely eloquent. Her arguments were heartfelt, and
you talk about Doris Brown.
Yes,
Doris Brown.
Yeah. And she was making the case for equity in healthcare.
Yeah, and I truly believe that when you start looking at different methods of delivery, I think a Medicare for all type of system is what will provide that sort of equality. I mean, if you look at it, in a very third party looking at it without any sort of self-interest, I think you would end up coming up with a system that, what we can do is we can design whatever system we want. You know, there has to be buy-in from folks like this, folks who are legislating and believe that it can happen, and then, you know, listen to the you know, the experts. So it sounds like some of the folks who were activists weren't at the table, or some folks who were most knowledgeable maybe didn't get to testify.
Yeah. There are people in the single payer world who've been studying this for 20 or more years.
Yeah.
There's a famous couple in this world, or in this line of study, Steffi Wohlhandler and David Himmelstein.
Okay.
One of their studies was referenced by one of the economists. He got Dr. Himmelstein's name wrong, but you know, it's okay.
Yeah.
I mean, those are two people who are experts. I mean, they really could have spoken to all the details, and you know, the day will come when they will.
Yeah,
but
because this was just the first hearing.
This is the first hearing, and you know, as Representative McGovern said, he was hoping that I don't know, somehow that this panel wouldn't be so invested in single payer that they could speak a little more dispassionately. I guess I don't know. I mean, I really thought that the everyone except Dr. Blayhouse and Ms. What was her name? From the Galen Institute.
Grace.
Trace Marie Turner.
Yeah. Everybody other than those two was a proponent of single payer. Okay. It's just, you know, they didn't have you know, many years of study of it. I would say, although the lady from the Commonwealth was pretty well versed.
Yeah. Now there was some pushback from some Republicans on the panel. So here was Representative Rob Woodall from Georgia suggested he would prefer a system that focused on the truly ill and those most in need, such as Barkin, the person who's the ALS person, rather than remake the system or divert resources to otherwise healthy families. Barkin noted, though, that none of us can escape the need for medical care and that we don't always know when it will be needed.
That guy didn't really strike me as being very bright, honestly.
Which one, Rob Woodall?
Yeah.
Yeah. The thing is that
is he given any study to this at all?
Yeah, or any thought.
He's just sort of, you know, spouting some kind of a party line that doesn't make a whole lot of sense.
Right. Yeah.
And he knew it.
Yeah.
I mean, you could tell that he was in the middle of some sentence that was sort of rambling on about, you know, can't we try to help just the poor?
Yeah. Well, and the problem, of course, is if you just start taking care of the everybody in the emergency room or on intensive care, that's a very expensive proposition. Is the reason why you would want to mandate care of everybody is because really it's a like what Barkin says here is that at some point you're going to be the person in the emergency room, and while you're well, that's when you have to support the person in the emergency room, because at some point somebody's going to be supporting you in the emergency room.
It's called a risk pool. We're all in it.
We're all
Everybody
in it. Yeah, and the thing is that and the way insurance companies profit is by trying to keep the higher risk people out of their pool and the lower risk people in their pool, so they can make more money.
Right, and that's
by denying
that's the
service.
whole point of why a multi-payer system is inefficient. People talk about bureaucracy and inefficiencies, but what they mean is somebody calling to get an appointment being asked, well, what's your insurance? And then they're told, well, we don't take your insurance. Or you get somebody who has an insurance that the provider does accept, and then you know, the provider wants to, you know, provide some service or some product or something, and then they've got to go through prior authorization, and there's just this long system of phone calls and sitting on hold and waiting, and there's this negotiation back and forth. First it's denied, then the doctor has to come up with another, you know, argument as to why it should be covered. It goes on and on. And you have
and the doctor is just wants to provide care. They don't want to negotiate whether or not this drug is going to be.
And this all adds up to about 30% of your healthcare dollar going to this kind of ridiculous shenanigan.
Yeah, because it's not just the front desk person, it's not just the pharmacist. The doctor gets involved, the hospital gets involved.
Every medical practice has a huge billing department.
Right. Yeah, and the drug bills are just, I mean, and everybody's just sort of looking at this formulary, the list of drug costs, and going, gee, how are we going to afford this? You know, because the doctor is looking at their patient and going, man, I don't think that person's going to be able to afford $500 a month. You know,
there's that. Yeah,
you know?
I mean,
it's, so what can I prescribe here? It's like, you know, and because the drug companies are getting their major slice off the top. I mean, just major. I mean, and it's not just the drug company. It's also the pharmacist. It's also the PBM, the middleman, the broker, but that deals with the drug companies.
And that's the way our system is set up, because other countries don't have that.
No.
Right.
No,
they don't.
Their drug costs are approximately 50% of what ours are.
Of course, when we set up our single payer system, we could set up exactly that system and, you know, just keep it the way it is. But
well,
no,
absolutely.
I mean, that would be a choice. It would be a stupid
One of the economists did say that. You know, is it Brown? Was the
Baker?
Dean
sorry,
Baker? Yeah. He absolutely said, you know, drugs cost too much.
Yeah.
He looked at the legislators and said, you're going to have to decide how you want to deal with this, but there's a lot you can do.
Yeah.
And the main thing I think that he pointed out was that the big long patents that are being granted to the pharmaceutical companies need to have shorter expiration times.
Right. Yeah. And then also they have to probably have significant changes to their product. They can't just turn the pill from purple to green and say that this is another 17 years on my drug, because there has to be a significant difference. Or they can't be allowed to pay off a generic drug producer who has something that they're about to put online and say, okay, how about if I pay you 10 times how much you would have made on that generic drug if you keep it off the market for another 10 years?
And I'll keep charging 100% or 100 times
that's
more
right.
than what your generic
Yeah,
would
I mean,
be.
it's just like when they pay off politicians. It's the same thing, you know. it's you know, to keep it off the market.
I don't think Dr. Baker mentioned it that way.
No, I'm sure not. No, but you know, and then here's Arizona Representative Debbie Lesko. Meanwhile, said that she didn't know why the committee was holding the hearing at all.
She was angry.
She used her time to try to poke holes in the plan by walking through a hypothetical situation of how a hospital would go through the process of fixing a leaking roof under a single-payer system. She later asked if the plan would, quote, provide health care for illegal immigrants, unquote.
She was pretty worked up about that
I bet,
one.
yes, yeah. Arizona. Navi interjected to point out that the United States is already providing free health care to undocumented immigrants because of a 1986 law put into place by Ronald Reagan, the Emergency Medical Treatment and Active Labor Act.
Yeah, she didn't want to hear that either.
No, I bet not, yeah. And then Florida Representative Donna Shalala, former Secretary of Health and Human Services under, I think it was Obama, right?
Right.
Carter. Not Carter. You know, the guy in between. Clinton.
It might have been Clinton, right. Said that she thought that holding the hearing was a smart move. Tackling such a big problem takes robust debate, she said, rejecting Republican arguments that it's just too difficult or would simply take too long. Quote, Congress has demonstrated over and over again that they have the backbone to take on big problems, put their arms around it, and try to find a solution. I'm perfectly willing to debate the cost issue and how we're going to pay for it, but we're here because the employee system is deteriorating in front of our eyes, unquote.
That was awesome. I mean, I didn't know that she would come out that strongly for single payer because, you know, look at who she worked with for so many years.
Well, the thing is that, you know, Hillary Care was essentially, you know,
Obamacare.
Right. It was keeping, it was a
employer based.
Yeah. It was designed to keep insurance companies in business. And that's the reason why, you know, the Democrats lost the House in 1994 and from then on it was just downhill. You know, it was because I'm convinced that it's because Hillary, you know, decided to, behind closed doors, to come up with this healthcare system that was first and foremost designed to keep insurance companies alive. Yeah. And then at that point, Republicans were able to, because of the secrecy and because of the way they went about it and the way that was rolled out and Harvey and Louise or something, they were talking over the table and stuff about, gee, I don't know about this plan that Hillary has here. And then, you know, they were able to run against that and then and then that just was the Republicans took over in 1994. Essentially, Clinton caved and just became sort of a moderate Republican and passed the drug law and got rid of welfare and then
Crime bill.
crime bill, right? Well, yeah, right, crime
Don't
bill.
forget that one.
Yeah, and then ended up getting impeached and the whole, but
So
Still.
so I kind of thought she'd dig in her heels a little bit for
Yeah.
the insurance companies, but she didn't. She
Well,
was
well,
ready
maybe
to
after-
toss them over the
Well, maybe
over
after
the
that
rail.
experience, after living through the Clinton thing, and said, this working for the insurance companies just, doesn't pay out. It doesn't pan out. And he's saying this, that right here, the employee system is deteriorating in front of our eyes.
Yeah.
It is. I mean,
Yeah.
it's just, there's no controls. There's nothing. And it may be that, and now that there's no individual mandate, I mean, it's just going to start falling apart.
Well, the deductibles are getting higher.
Yeah,
The
yeah.
co-pays are getting higher. The
Yeah.
premiums are getting higher.
And the insurance company profits are
the
getting
the networks are getting narrower. I mean, it's
Yeah.
just getting less and less appealing to workers. When I hear these surveys where they say things like, 90% of people with employer-based health
Are
programs
happy with their
I'm
si-
like, no, they are.
Well, compared to what? Compared to nothing?
Yeah,
I mean, that's the thing. Is this
Well, they're afraid that they're going to lose their employer.
What little they have.
Yeah.
I mean, they must be talking to people who haven't had to use it. That's all I can think. Because as soon as you have to use your health plan that's employer-based, you
Yeah.
realize how inadequate it
But
is.
if you
Exactly.
live in fear of losing that,
Yeah.
Well,
Yeah.
I know, but why would you
Right.
say you like it?
well,
because when you're
because you want to keep it.
yes, because you love this lifeboat. you did, even though there's sharks driving around. I love this lifeboat, even though it's a really stinky old lifeboat. It's keeping me afloat. And that's the problem. So anyway, so from here on out, it sounds like the two committees with the most significant claims of jurisdiction over the bill are Ways and Means and Energy and Commerce. Frank Pallone, who's the Energy and Commerce guy, has yet to agree to hold a hearing. But on Tuesday, Jayapal told reporters that Ways and Means Chair Neil had agreed to hold one. Neil,
Oh, that's exciting.
Yeah, Neil announced his support of a hearing at a private Congressional Progressive Caucus gathering that met as the rules hearing was ongoing. So that Ways and Means is a pretty big, and then that's where maybe some of these folks who are these activists
money
or advocates or
questions,
some, who will be able to, money questions indeed. And then Budget Committee Chair Yarmouth from Kentucky said he would also hold a hearing on Medicare for All, though he hasn't scheduled a full hearing with a variety of witnesses. He has requested the CBO, the Congressional Budget Office, analyze elements of the bill. A report expected to be released Wednesday afternoon. I guess that was last Wednesday,
Last Wednesday.
maybe. No.
Well, the hearing was
well,
on
Tuesday.
Tuesday.
I don't know. I don't know if they
Maybe
could do it, turn it on
in
that
2
fast.
days. Yeah, I don't know.
He plans to follow up by inviting the CBO to testify about the results. Oversight and Government Reform Committee also has jurisdiction, and as chair, Elijah Cummings is a supporter, though that committee has not scheduled a hearing either. So that is, so the bill that was the subject of Tuesday's hearing was authored by Representative Pramila Jayapal. And
1834.
1830,
Or is it
that's-
1384?
1384.
Sorry,
1384.
yeah, 1384.
And it would enhance Medicare's benefits, eliminate co-pays, deductions, and premiums, extend coverage to all American residents. Pretty simple.
And I just want to mention, since I think you mentioned the CBO, they just came out with a report on single payer.
Well, maybe that's the one they were talking about.
Yeah,
It was coming
a
out on Wednesday.
34-page report that's
Very
out.
good.
So you can go to cbo.gov, I think, and find it.
So it says here though, now, so this is 2019. And so what we have is we have a Republican Senate and we have Trump.
There's that.
And so, without a hearing or a vote on major committees, this Jayapal bill is unlikely to get a vote on the floor of the House this term. And in the Senate, meanwhile, McConnell has suggested he may hold a version of the vote, but only as a way to try to put centrist Democrats in a tough spot. I don't know if it's a tough spot
Well,
at all.
I hope it backfires on him.
Yeah.
I really do.
Yeah, I think so, because the number one issue that motivates Democrats is healthcare, and regrettably, the number one issue that motivates Republicans is immigration.
Yeah.
And so, I don't know well, I don't know if a single payer healthcare is going to solve the immigration problem, but it may motivate Democrats to get out to vote, because if there is a clear choice, if there is a bill that is out there,
an opportunity, a possibility.
If they have hearings, and people should notice the Ways and Means Committee is going to be holding hearings, at least one hearing. The Budget Committee says they're going to have one, and this is all on the House side, of course. And then Mr. McConnell is going to have some sort of vote, probably without even going through committee, because he just wants to vote on something that nobody's even discussed. So that's just a political ploy.
One thing that concerns me is that the national media seems to refuse to talk about Medicare for all.
Right.
Well, there's that.
Yeah.
Who's buying all the commercial time? I mean, it's drug companies and
how are people going to
Medicare
find out about
Advantage
it?
plans.
I guess we have all of these people are going to run for the Democratic nomination.
Well, people who listen to this station,
social media.
Well, yeah. Well, the thing is I think a lot of people are just sort of turning. I mean, I'm just looking askance at a lot of mainstream media stuff and going, man, you have to be aware, and you have to be really skeptical of just about everything you hear on the media these days, because you just have to try to understand where people are coming from, where their angle is, who pays their bills, and try to figure out why something comes out. I mean, something like this that is pretty darn. I mean, it's universal throughout the world except for here. I mean, how can there must be some motivations as to why the media is not covering this in a fair-handed way.
Yeah, that's what I don't
What
understand.
could that be?
Yeah, well,
It could be money, or it could be money, or maybe it's the money. But yeah, I mean, the things that people have to really listen and just get the facts. I mean, go to C-SPAN. Go to watch these hearings. The Intercept is go to intercept.com. Intercept.com is it's a good magazine. They dig some stuff up.
Yeah, they do.
Yeah, and I look at Truth Out, and I look at Reader-Supported News, and I look at Alternet, and
Common Dreams.
Common Dreams, exactly. And so you go through these websites, and the thing is that a lot of the information there is just very good information. And the thing is, the more you read about stuff, and the more you compare it against the stuff that you see in New York Times or the LA Times or Boston paper or whatever, and if you watch the network news, or if you watch any of the, just take in all of that stuff, and just try to listen for things that sound like they make sense, that they're true, that they're not people who are just not pointing to facts, but what they're doing is they're pointing at opinions or horse race types of issues, or like when we're talking about the presidential campaign, let's focus on the issues. Let's not talk about whether or not somebody parts their hair on one side or the other, or whether or not they're the flavor of the month or whatever. I don't care what Mayor Pete wore this morning. I just want to hear where does he stand on Medicare for all? Where's Beto O'Rourke on that? Where's Kristen Gillibrand? Where are these people on issues that are important to us? And issues are the things that get decided. If you vote for somebody who you'd like to have a beer with, you'll end up with George W. Bush. Or if you want to vote for somebody who makes you feel good, but who doesn't necessarily say that he's going to do anything, you vote for Barack Obama. Because he is a real nice guy. He's real classy. Boy, I sure do wish makes me want to go back to Barack Obama. Well, the thing is the guy didn't get stuff done, and if
he didn't fight for it.
No, right. And the thing is, he was fighting against. Yeah, everybody fights against things. You have to do it. And George W. Bush. Well, looking at Trump makes me really maybe pine for George W. Bush. Have you lost your mind? I mean, my God. I mean, the thing is that we have to have standards. We have to have standards, and a problem is that we just have to establish our own standards. We have to look at what we want to have, and we have to fight for it. And one encouraging thing was in 2018, there was a really good election. There was a lot of turnout. There was a lot of diversity that ended up happening in the House. I mean, in the Senate, we ended up, getting sort of more of the same old, because the Senate is sort of a backward institution. I mean, I read somewhere that in order to control the Senate, you only have to get 18% of the vote.
I think 30% of the country elects 70% of the Senate.
Yeah.
And, and they're
Yeah.
from small
There
red,
you go. Small
slightly
states.
populated red states.
Now there are some
there are
some tiny blue states like Delaware or Rhode Island,
right?
or
they're a little
Massachusetts.
unfairly,
Compared to California,
disproportionately
shall we say,
right? Yeah.
39 million people, 2 senators. That's not quite right, but that was it.
Yeah.
But anyway, so it was a good hearing. It sounded like it was a good time. That was
much more positive than I anticipated.
Right. I was pretty pessimistic going into it, but
Yeah.
what I said
McGovern's
about this time last week. Sorry to interrupt you. Is that this happened at all because the people wanted it. This was not driven by any special interest. This was not driven by any real legislators. They're only doing it because we're making them.
That's right.
Yeah.
That's right. Yeah. It's sort of like Vietnam War or something, I mean, it's like where, where people actually, get up and stand up and say, this is what we want.
Yeah.
And
we've got a ways to go yet before we're there.
Well, yeah, definitely.
Right.
I mean,
but we got one hearing and we've got another one on the way.
you start by discussing it, and to think that, Medicare for All was not. I mean, it was a throwaway line 3 or 4 years ago.
Yep.
Before Bernie ran,
laughing.
presidential campaigns are really important because they do raise issues to the level. And it's a nice thing to have 21 people out there because they're gonna. I mean, they may sound like they're talking all over each other, but they all have issues.
Before that, the only way we could talk about single payer was in California.
Yeah. As a possible state by state thing.
Right.
Yeah.
Right. Yeah, but the thing is, you can't really do it state by state.
No.
It's something
Well,
that
you can.
Well,
That's what Canada
it's not
did.
optimal.
Well, in a big state like California would have a chance, but one of the arguing points of the lady from the Galen
Turner.
Institution,
Turner,
sorry, was that it failed in Vermont and it failed in Colorado.
The point she said, she talked like they had put it in effect. They did not.
Right, it didn't pass their initiative, or the governor vetoed it.
Vetoed
or,
it,
whatever.
yeah,
I mean,
yeah.
but
so it wasn't in effect there. It was the Republican governor vetoed it. So I don't know what she's talking about. It didn't fail there.
Yeah. Well, what we need is a looking at it holistically and as an entire country, because really it is sort of like a civil right. It's a basic right. It's something that everybody deserves. Just because you live in Alabama doesn't mean you should get a worse care than if you live in Connecticut. There are standards, or there is a base.
If we had to go on a state by state model, if we had to do it that way, we would, but that wouldn't be what we really want.
No.
What we really want is a nationwide program.
Right.
Absolutely.
Right. So anyway, we're about up for time. Is there anything else that struck you from that hearing that we haven't covered? That was, or anything else that's going forward? Because we'll come back to talk about this in a few months.
I did hear one statistic that I have looked for a long time. The Medicare for the senior advantage programs cost between 12 and 17%. So that's a big tax
12
bite.
and 17% more than regular Medicare. Is that what you mean? Or?
Well, more than that's what you pay. Than if you took out a policy, some other policy on your own. Those cost 12 to 17.
Oh, then if you bought a supplemental, you mean?
Right.
Oh, okay. They cost more than a supplemental plan.
Right.
Okay.
But it's paid for by tax dollars.
So the thing is that I would say Medicare for all. I'd like to see it all covered. I'd like to see I show my card.
Everybody in, nobody out.
That's right. That's right. Because the thing is I don't want to have any I don't want to have anybody, turned away or dissuaded from going to a doctor because they think, oh God, I can't afford that. Because the thing is that when people are healthy, when people are healthy, they'll stay healthy. And I'm sure there are some anecdotal people who are just always sick. But generally, if you change your oil every 3,000 miles, you're going to be in better shape than if you wait until you have 50,000 miles and your oil filter blows.
That's really something coming from you, Bruce.
Yeah. Well, one of these days, when we get a single pass. Touche. Anyway, very nice. So this has been Peace and Justice Connections with Dr. Kathy Mathis and Max Heinemann. We've been discussing Medicare for All after the hearing. Thank you very much for listening, and keep your eyes open for further developments. Thank you. Good night.
KBCC 89.5 FM, Tracy, California, Peace and Justice Network of San Joaquin.
Do you want to relive the golden days of Stockton? Join Nate Knott on Stockton Alive every first and third Monday at 6 p.m. Tune into thevoiceofstockton.org.
Escuchan a KXVS 92.1 FM, la radio de la comunidad. La radio de la comunidad. Gracias por su sintonía. Noticias y algo más. El Profe Cortés, Mondays and Wednesdays 4 to 6 p.m. for exclusive Spanish news. Sin filtre.